Hello, fellow veterinarians. In the last lecture, in part first of hyperparathyroidism, we discussed about the what is hyperparathyroidism in canines and felines, and what are its causes. What is primary hyperparathyroidism? What is secondary hyperparathyroidism? And what is tertiary hyperparathyroidism? Okay, and after that we discussed about the complications of hyperparathyroidism, in which we discussed how it leads to the kidney stones, urolithasis. Okay, how the hypercalcemia that's found in the hyperparathyroidism, it leads to the osteopenia, osteoporosis, and finally the pathological fractures. Okay, the third most important this complication of hyperparathyroidism is, whenever you will get a case of hyperparathyroidism, kindly check it for pancreatitis also. Okay, you have to get a panel of lipases, okay, and amylases. Why? Because this, in hyperparathyroidism, you know that there is hypercalcemia. Okay, hypercalcemia. And what happens, this calcium is important for the excretion of excretion of lipases from pancreas. Okay, so whenever there is, this is the normal, whenever there is normal concentration of calcium, and there will be normal secretion of lipases from the pancreas. So whenever there is hypercalcemia, there is increased concentration of calcium in the blood, it will lead to the increased or uncontrolled secretion of lipases from the pancreas, and this leads to the pancreatitis, that is the inflammation of pancreas. So whenever you are dealing with a case of hyperparathyroidism, always look it for pancreatitis also, and evaluate it through increased lipases and increased amylases. So, and along with, you can coordinate this, or you can confirm these biochemical findings from the clinical signs also. And you all know that in the pancreatitis in small animals there is epigastric pain. Okay, you will see a severe abdominal pain in the canines and felines. So this is the another complication, that is pancreatitis. Okay, now the fourth major main one of the main this complication of hyperparathyroidism is, so let me make clear. Now, if this is the glomerulus, this is the nephron structure. Okay, now what happens normally, there is the ADH, antidiuretic hormone. It works on these, there are the special type of receptors and present at the collecting duct. Okay, there are the special type of receptors called V2 receptors. And what does V2 mean? It means vasopressin receptors. These receptors are present on the collecting duct. So normally what happens, that this ADH, it binds with these V2 receptors. When it binds with these two V2 receptors, it helps in the, what it helps in the reabsorption of water from this collecting duct to the back to the circulation. Means it maintains the normal osmolarity, it maintains the normal osmolarity of, this, wait, means it maintains the normal this osmolarity of this blood. Okay, so this is the normal ADH, it binds to these V2R receptors, and it will cause the reabsorption of water from this fluid from the collecting duct into the circulation. Okay, now whenever there is hypercalcemia, okay, there is hypercalcemic condition, so this calcium will compete with the ADH, and instead of binding to this instead of binding to the wait, instead of binding to the this ADH, there will be the binding of calcium. Thus calcium will replace the ADH and it will bind to these V2R receptors. When it binds to these V2R receptors, what will happen? It will not lead to the reabsorption of water. Okay, what does this mean? This urine will become more diluted. Okay, it will become more diluted, means this water will not be reabsorbed, then the volume of urine will increase. And what does that mean? It means it leads to the polydipsia. Okay, so one of the finding in hyperparathyroidism, we will see there is polydipsia. What is the mechanism? This is the mechanism how this hypercalcemic state leads to the polydipsia. Now polydipsia, whenever there is this polyuria. Okay, polyuria, whenever there is polyuria, it will lead to the dehydration. Okay, and when there is excessive dehydration, it will stimulate the hypothalamic thirst center, and it will lead to the polydipsia. So this is the reason why there is polyuria, dehydration and polydipsia in case of the this hyperparathyroidism, and this is the mechanism. Okay, these are the complications of this hyperparathyroidism. And one more complication is in case of the, I told you in hypoparathyroidism that if you want to see the ECG changes, remember calcium concentration is inversely proportional to the QT interval. What does this mean? It means that whenever there is increased calcium, there is hypercalcemic state, it will decrease the QT interval. So here what will happen in the hyperparathyroidism? There will be decreased QT interval. So this is the ECG finding, and it will lead to the arrhythmias. Okay, mainly bradycardia. You will see bradycardia in hyperparathyroidism cases. So these complications you have to remember that there will be nephrolithiasis or urolithiasis. Okay, there will be pathological fractures, and also evolve for pancreatitis. Okay, and polydipsia, polyuria and dehydration. Okay, these are the complications of hyperparathyroidism. Now what is important in hyperparathyroidism is, let us discuss about the diagnosis part of hyperparathyroidism. In diagnosis, whenever you will get a case of hyperparathyroidism, first of your approach should be get a constructed history from owner. Okay, you will ask some questions to the owner, that is there PUPD, that is there polyuria, polydipsia. You will evaluate it for dehydration. Okay, you will see whether there was any episode of like uroliths or nephroliths were found, and was the same case treated for that, or is there any recurrency. Okay, you will see was there any abdominal pain. Okay, and sometimes you will see vomition also, and you will evaluate for these any bone deformity, like is there any fracture or something like that. So you will evaluate, you will get the proper history and other clinical examinations. Okay, you will evaluate it thoroughly. Now after that, you will tell the owner to get a obtain serum calcium and phosphate. Okay, you will tell the owner to get a serum calcium phosphate. Suppose you will get the increased calcium and decreased phosphate. So what type of hyperparathyroidism it could be? It could be either primary or tertiary. I discussed it in there is increased calcium, hypercalcemia, either in primary or tertiary, and decreased phosphate either in primary or tertiary. Okay, so this is the you will confirm it by getting increased calcium and decreased phosphate, and on the basis you will describe it as either it is primary hyperparathyroidism or it is tertiary hyperparathyroidism. Now after that you will tell the owner to get a renal panel. Okay, renal panel. Suppose in the renal panel and PTH, suppose there is increased PTH and decreased GFR. Okay, and there is increased PTH and normal GFR. Okay, in first instance you get the increased PTH and decreased GFR and increased phosphates. Okay, here you got the increased PTH, normal GFR and decreased phosphates. So on this basis you will diagnose it as this is a tertiary hyperparathyroidism. Okay, you just go to the my previous lecture and watch that thoroughly. You will get to know that what are the findings in tertiary hyperparathyroidism. In tertiary hyperparathyroidism, in both cases primary and tertiary, you will see increased PTH, but in tertiary hyperparathyroidism, since there is this is also associated with either with the CKD, so there will be decreased GFR and also other renal panel, this what we call as renal panel parameters. Okay, and there will be increased phosphates, and here since there is increased PTH but there is normal GFR and also decreased phosphate, so it could be primary hyperparathyroidism. So on this basis you have to go step by step in order to evaluate the patient, in order to reach the final diagnosis. So before after getting the history you will obtain the serum calcium phosphate, and in the serum calcium phosphate if you got increased calcium and decreased phosphate concentration, so it would be primary hyperparathyroidism or tertiary hyperparathyroidism. If you want to further evaluate it, then get a renal panel, particularly GFR, okay, and PTH. Okay, if there is increased PTH and with decreased GFR, it could be tertiary, and if there is increased PTH and normal GFR, it could be primary hyperparathyroidism. Second instance could be there could be decreased calcium and increased phosphates. Okay, we can say normal or decreased calcium or increased phosphates. Okay, so possibly this is secondary hyperparathyroidism. Okay, but you won't stop here, you will obtain the PTH and vitamin D. Okay, get a serum PTH and vitamin D. So if there is increased PTH, okay, so since there is increased PTH, so this is secondary hyperparathyroidism. Now you will get a renal panel. Okay, you will get a renal panel. In the renal panel, if there is decreased GFR, okay, and also there is increased PTH, it means that this is CKD related secondary hyperparathyroidism. Okay, now if there is decreased vitamin D, okay, and normal GFR, it means it is vitamin D dependent secondary hyperparathyroidism. This is the this is the approach for diagnosis for the critical. This will give you a constructive diagnosis in hyperparathyroidism. Okay, and this will help you in the treatment of your case. Now this is regarding the diagnosis. So now let us move to our last segment of this, that is the treatment part. Treatment part. Now in the treatment of, let us discuss the treatment of primary hyperparathyroidism. Here you know that there is no CKD, means kidney is okay, means we have to only treat hypercalcemia. We have to treat hypercalcemia. Okay, so let us see the approach that is followed to treat the hypercalcemia. For the initially, when you will get the treat case of this hyperparathyroidism, remember you will first evaluate it for dehydration. Okay, you will first evaluate it for dehydration, and as soon as you will get the clear diagnosis that this is the case of primary hyperparathyroidism, then you will start your treatment. Okay, first we have to go for fluid therapy. Since this fluid therapy, it is considered as the cornerstone of the management of hypercalcemia. Okay, and the fluid of choice in the treatment of primary hyperparathyroidism is 0.9% normal saline. Remember this is important for your examination point of view, also for your clinical practice. So how it is given? This is the fluid of choice. Now it is given at the rate of 5 ml per kg per hour. Okay, it is given at the rate of 5 ml per kg per hour. Up to what extent this is given? It is given to the extent that the dehydration resolves. You are feeling that there is now no dehydration in the animal, and then you will stop here. Okay, what is the mechanism why this is the fluid of choice, that this normal saline is used? The normal saline, then sodium in the normal saline, it competes with the calcium. Okay, calcium, it competes with the calcium and reduces its tubular reabsorption. Okay, since you all know that in the calcium is also reabsorbed from the tubules, ADH plays a vital role. And here this, whenever there is sodium also present, we are giving 0.9% normal saline, this sodium will not allow the reabsorption of calcium. Okay, and it will lead to the diuresis of this calcium will be secreted through urine. Okay, so this will decrease the level of calcium, decrease the hypercalcemia in the animal. So this is the mechanism that why 0.9 normal saline is used, means it increases the renal loss of calcium in the animals. Okay, now when you have resolved the animal that there is no dehydration, you will manage the animal. Now when the animal, for you the animal is optimally hydrated. Okay, optimally hydrated. Now you will give another drug, that is furosemide. It's a diuretic given at the rate of 2 mg per kg body weight. Okay, 12 hourly it is given. It will, furosemide, it will lead to the diuresis, and it will further decrease the calcium, or in other words we can say it increase the renal loss of calcium. So it will decrease the calcium level in the blood. So this is the second. First you have to go for the fluid therapy. I told you thoroughly, 0.9% normal saline at the rate of 5 ml per kg per hour, and then you have to use the furosemide. Okay, but here is a catch. What is the catch? This is important, you have to remember. While giving the 0.9% normal saline and furosemide, kindly look for the potassium levels. Okay, potassium, because normal saline and these diuretics, these also lead to the renal loss of potassium. Okay, this will decrease the potassium levels in serum. Potassium levels are decreased because of these two drugs. So we have to also see the whether the potassium levels are maintained or not. Why? To avoid hypokalemia. Now, if despite this treatment, this management, if the serum calcium level is not decreased to the normal, then we have to approach further treatment protocols. Let us discuss them one by one. Okay, first treatment that is widely approached is use of glucocorticoids. Okay, glucocorticoids are used for the management of hypercalcemia. They are used at the rate of 1 mg per kg body weight. Okay, OD, once a day. Now, what is the mechanism that these glucocorticoids, these glucocorticoids help in the treatment of hypercalcemia? Remember, glucocorticoids are always and only used in those hyperparathyroidism cases, in those primary hyperparathyroidism cases where there is the lymphoma. Okay, suppose there is the lymphoma of parathyroid gland. Since there are two types of lymphomas in the body, one is Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphomas. So whenever there is, since non-Hodgkin's lymphomas of the parathyroid gland have been seen, what are these Hodgkin's lymphomas? Not the mandate of this lecture, since lymphomas are the cancers of lymphocytes. Okay, so and these non-Hodgkin lymphomas, what is the difference between these two? The difference is that in for your examination point of view, Hodgkin lymphomas, there is a special type of cells, Reed-Sternberg cells are seen, and in non-Hodgkin's, no Reed-Sternberg cells are seen. Here the prognosis is very grave, and here the prognosis is not so grave. Main difference is Reed-Sternberg cells in Hodgkin's and no Reed-Sternberg cells in. What are these Reed-Sternberg cells? These are the defective lymphocytes. So this is not the mandate of this lecture, but remember, glucocorticoids are only used in those hyperparathyroidism, primary hyperparathyroidism cases where the clinician is certain that this hyperparathyroidism is because of the parathyroid gland lymphoma. Okay, so what is how these glucocorticoids help? First mechanism of action is these lead to the lysis of lymphoma. Okay, whenever there will be lysis of lymphoma, there will be decreased PTH excretion, so it will decrease the calcium level in the blood. So first mechanism, direct lysis of lymphoma. Second is it increases the renal calcium loss. Okay, this is the second. Third is decreases the intestinal calcium absorption. Okay, this will further decrease the calcium level. Okay, and fourth is decreased bone reabsorption. Okay, it will also decrease the calcium level. And fifth is it has an antagonistic role on vitamin D. Okay, so these are the mechanisms of action, how these glucocorticoids work. And remember, they are only used when you are certain, when a clinician is certain that this hyperparathyroidism is because of the lymphoma. Okay, so you won't find any response because using these glucocorticoids in other neoplasias except the lymphoma. So these are also used. So this is the second therapy. Third one approach is using bisphosphates. How these bisphosphates work? These are the potent antagonists of osteoclasts in bones. How they lead to the apoptosis of osteoclasts. Okay, when the osteoclasts are dead, so there will be no reabsorption of calcium from the bones, so it will decrease the calcium level in the blood. So remember how they work. Now there are some of the bisphosphates like chlordronate, okay, like alendronate, dronates. Whenever you will find dronates, these are bisphosphates. Etidronate, okay, palmidronate, and zolidronate. Remember the first three: colidronate, chlordronate, alendronate, and etidronates. These are used, these should be used oral, okay, empty stomach when given, they show better absorption. But the side effect of these chlordronates, alendronates, and etidronates is that these are irritants. When given the per oral, these are irritants, and it has been seen they lead to the esophagitis. Okay, that's why these are disarmed. They are not used widely. The palmidronate, the palmidronate, it is considered, it is more this palmidronate, it has not been widely used. Why? Because if given, it has seen that it leads to the osteonecrosis of jaw in canines and felines. Okay, so that's why it's not widely used. Zolendronates, it is considered as the drug of choice. Why? It is the more potent than palmidronate. Okay, it is more potent than palmidronate, and it is given at the dose rate of 0.1 to 0.25 mg per kg body weight. Okay, 0.1 to 0.25 mg per kg body weight, diluted in 45 to 100 ml of 0.9% normal saline, and given intravenous over 30 minutes. So this is the drug of choice, it is palmidronate. There are also other therapies like calcitonins are given. Another drug, pilcamycin, it is also given. So this pilcamycin is not used because it leads to the hepatocellular necrosis. Okay, so this is the management. Now what is the definitive therapy? Okay, what is the definitive therapy of hyperparathyroidism in dogs and cats? Definitive treatment. The first one is surgical parathyroidectomy. Okay, if for this you need an expert radiologist, and the radiologist, if the radiologist is certain that the parathyroid nodule is more than 12 mm, then go for parathyroidectomy. Okay, it should be more than 12 mm. First you have to identify it by using ultrasound or CT scan. If the sonographer or if the radiologist is certain that it is more than 12 millimeters, then you have to go for surgical excision. Okay, so this is the surgical parathyroidectomy. Second one is percutaneous ultrasound guided ethanol ablation. Okay, what is it? First you have to identify the parathyroid nodule by using the ultrasonography. If it is more than 3 millimeters in size, okay, then an expert using the 27 gauge needle is inserted in the parathyroid nodule. Okay, and through that needle ethanol is inserted in the gland. How the ethanol treats it? Ethanol, it leads to the coagulative necrosis of cognitive necrosis, and thrombosis of in the parathyroid gland. So this is the percutaneous USG guided ethanol ablation, but it needs an expertise. Okay, it needs an expertise. It needs the evaluation by the expert radiologist and an expert surgeon. Okay, why? Because when you are inserting the needle, 27 gauge needle, you have to take the care of carotid artery and vagosympathetic trunk. Okay, because these two are in close proximity with the parathyroid gland, so these should not be compromised. Okay, and the third one is percutaneous USG guided heat ablation, not very much used. So this is the treatment of this parathyroid hyperparathyroidism. So one more and now what about the management of hyperphosphatemia? For that, the phosphate binding agents are used. Like there are the some of the oral intestinal phosphate binding agents, ammonium hydroxides. Okay, second one is calcium carbonate. Ammonium hydroxide is used at the rate of 10 to 30 mg per kg body weight. Okay, 8 hourly with meals. And calcium carbonate, same dose rate, 10 to 30 mg per kg body weight with meals. So this ends our this hyperparathyroidism. Hope you understood each and every bit of it, and I tried my best to make it clear. So if there is any question or any confusion, you can jot down in the comment section, and I will, if I am able to answer, I will definitely answer the your valuable questions. So this is the basics regarding the hyperparathyroidism that will help you in examination point of view as well as your for this clinical practice. So keep supporting and keep sharing. Thank you so much.